Okay, I'm starting. Okay, friends. Just let me see the connectivity and the connection. Okay, I'm starting. Okay, fine. Okay, friends. Just let me see the connectivity. Okay, that's fine. So let's start. Recall questions. Around four questions I could manage to get. So if you have other questions right now also you can post me and we can discuss. Okay then, let's start. Question number one. Which inhalational agent requires a special vaporizer for its delivery? Halothane, isoflurane, desflurane, sevoflurane. Vaporizer, is the equipment which is used for the delivery of inhalation agents. Like if I show you, this is a screenshot of our notes. So these are vaporizers which are used for the delivery of inhalation agents. Like older times you see, these are also vaporizers, but these are older ones. These are not used nowadays. So this is an old machine, photo of an old machine. So nowadays we are using these kind of vaporizers. So vaporizers are categorized based on many technical specifications like Tech 5, Tech 6. Anyway, though all those details are not required for you. So important thing about vaporizer which you can know is that vaporizer are used for the delivery of inhalational agents, and current day vaporizers, there are two most important property that you should know, that they are temperature compensated, and again it's a screenshot of our notespedia. So otherwise what happens, these inhalation agents, they are volatile. So when inhalation agent evaporate, its temperature will fall, and that will lead to decrease in the output of inhalation agent. So with the passage of time, their output will keep on decreasing. So nowadays the newer vaporizer, they are temperature compensated, means whatever the changes happen in temperature, their output will remain constant. So you can rely on the output will not change. Secondly, they are agent specific, means you cannot fill one agent with the other, and that is why they actually have given color coded for these vaporizers. So red color vaporizer will be halothane, purple isoflurane, blue desflurane, and yellow is sevoflurane. Like say if we see in our diagram, you can see this yellow mark. So that means this is a sevoflurane vaporizer. You see this purple mark, means that is your isoflurane vaporizer. Fine. So desflurane will be blue color. Now, let's come back to our question. Which inhalation agent require a special vaporizer? Actually, desflurane is unique among all these inhalation agents, that it has very low boiling point. Boiling point is around 23 degrees centigrade, and very high vapor pressure. Vapor pressure is around 680. So it means almost 700 mmHg. So imagine at 1 atmosphere and at room temperature, it will boil. It will start boiling. And imagine if I inhalation start boiling at room temperature, and vapor pressure is high, means it will vaporize too much. So enormously high concentrations will be delivered. So obviously because of these two properties of desflurane, that is high vapor pressure and low boiling point, makes it a different agent from other inhalation agent. So obviously cannot be delivered through ordinary vaporizer. There is a special vaporizer for the delivery of desflurane, that is called as Tech 6. So Tech 6 is a special vaporizer which is used for the delivery of desflurane. Fine. So answer is C. So low boiling point and high vapor pressure makes desflurane that's not possible to deliver it through ordinary vaporizer. So a special vaporizer, that is Tech 6, is used for the delivery of desflurane. Now there are many other features which compensate for this high vapor pressure and low boiling point, but of course that much details are not required for you. Question number 2. A known case of asthmatic bronchitis reported to hospital with breathlessness, palpitation with oxygen saturation of 88%. Hospital has no ventilator. All of the following can be given to the patient except hydrocortisone IV, antibiotics, oxygen with the oxygen mask with reservoir, nebulization with salbutamol. This was very much expected question. Why? Actually, during the COVID period, and you would have seen last 3-4 times, definitely there is some question related to the delivery percentage of oxygen of each of these oxygen delivery devices. Although nowadays you know that happy days of directly asking the questions have gone. Now they are asking the same fact but with clinical application. Like they should know that how much should a oxygen delivery device produces FiO2 or delivers FiO2. Like, so oxygen delivery devices, you know, has been broadly classified, again screenshot of our notes, high flow systems and low flow systems. So high flow systems, you know, are fixed performance devices, means their performance or their output remains largely fixed. Variable performance means that their output keep on varying with the changes in the patient respiratory parameters. So your high flow, that is fixed performance, are Venturi mask. Actually, oxygen mask with reservoir, I won't be classifying it as a high flow system. This is more or less low flow system. I'll tell you why. Nasal cannula, oxygen mask, and in fact, I will like to use oxygen mask with reservoir. Some people have classified as high flow, but that's not an appropriate thing. More or less, it should be classified as low flow system. Fixed performance means that their output is going to be fixed. So obviously they are more accurate in terms of oxygen delivery, or they are more reliable in terms of oxygen delivery, or you can say their oxygen delivery can be regulated. Variable performance means their performance keep on varying. So they will be less accurate, less reliable. Their delivery cannot be regulated. Fine. Now look at the maximum oxygen they can deliver. And in that, I will add one more thing, at maximum flow. This is very important. For last 3-4 years, I'm telling you 3-4 times, you will be seeing some questions related to this. So with the nasal cannula, maximum oxygen you can deliver is around 40 to 50%, and flow is 6 liter. So at 6 liter of oxygen flow, this is the performance you are going to see, around 40 to 50%, or say for example, say average, let's take 45%. So 6 liter you will see 45%. After that, whatever oxygen you increase, output is not going to increase. So that is important. I've seen people using 10 liter, 15 liter with nasal cannula. So they are simply wasting the oxygen. Simple oxygen mask, maximum flow is 10 liter and maximum you can say is 60%. Venturi mask, maximum flow is 15 liter and maximum oxygen is 60%, but this 60% is reliable, accurate. Here the 60 may become 50 or 40 depending on the patient respiratory parameters. While here Venturi mask 60 means 60. Oxygen mask with reservoir deliver very high, almost 100%, 80 to 100%. And that again is seen at 15 liter. Fine. So this is one, you can say, application you have to know. Now let's come back to your question and see what they want to ask you. Patient with asthmatic bronchitis, you know, high oxygen concentration can be lethal to them. It's very detrimental. Why? Because these patients, you know, their respiration depends on hypoxia. their breathing is hypoxia dependent. So don't be much bothered about oxygen saturation of 88%. Yes, for a normal patient, 88% should raise an alarm. However, for COPD or asthma patients, you see that their baseline oxygen saturation is always less. So the most important thing is that you should not give high oxygen, and that is what they wanted to ask you in this question. Oxygen mask with oxygen reservoir is delivering more than 80%. So if you give such high oxygen to asthma patients or COPD patients, that can turn out to be a lethal event. So for this patient, we will be delivering oxygen, but with the nasal cannula, and I'll start with 2 liters of flow. That's it. So 2 liters means it will be delivering somewhere around 24 to 25% only, or 24 to 28%. 1 liter it is 24%, so 2 liter will be around 28%. 80% is very dangerous. So that is what they wanted to ask in this question. Fine. So we will not deliver oxygen with oxygen mask with reservoir. We will be giving oxygen with the nasal cannula just with 2 liter. And sometimes you will see they will become comfortable after some time. Saturation even if become just above 90, I may decrease it to further 1 liter. Fine. Hydrocortisone IV, patient is asthmatic bronchitis and breathlessness, and obviously patient has acute attack of asthma, so there will be wheezes, so patient will definitely respond to intravenous hydrocortisone. Asthmatic bronchitis, so we are expecting that there can be infective component, not necessarily. So you can give antibiotic if there is fever or some other signs of infection, like white cell count is high. And of course, nebulization you will be doing either with salbutamol anode, or you can use butyrocortisone, that is steroid also. So fine. So answer is C. Question number 3. Before laparoscopic surgery, what advice should be given to the patient? NPO 8 hours before OT, NPO 24 hours before OT, NPO 2 hours before OT. No need for NPO in laparoscopic surgeries. Nil oral guidelines. Nil oral guidelines. So nil oral guidelines are very important that you must know. And nil oral guidelines, again our screenshot of notes. Nil oral guidelines, that is fasting, is very important, and you should be actually strict about fasting, because aspiration is a complication of anesthesia for which you will only be responsible, not surgeon. It's not surgical complications like if there occur bleeding or hemorrhage during surgery, so surgeon will be more responsible. Okay, you have part responsibility of managing shock, but primary responsibility lies with surgeon. But here this is a complication considered to be anesthetic complication, so that you cannot take that risk. So fasting should be adequate, and fasting guidelines are solid food 6 hours. However, if the patient has taken fatty non-veg meal, that fasting should be 8 hours. Clear fluids, that is water, can be given up to 2 hours, while breast milk can be given up to 4 hours. So clear food means only water, or you can say tea without milk, coffee without milk, or plain juices without pulp, you can also consider as clear fluids. So if patient has taken tea with milk or coffee with milk, then patient should be considered that he is having unclear fluids, and a fasting of 6 hours will be mandatory, because this is a very common problem that we encounter in our day-to-day clinical practice. Surgeon will come to us and they say, oh no, just patient has taken just tea and maybe just one biscuit. No, tea with milk, full 6 hours. Without milk, plain tea, yes, clear fluid, maybe 2 hours. And that is why we ask detail about the diets, not only fasting hours, what the patient took. If patient has taken fatty non-veg meal, then we have to wait for 8 hours. Otherwise, normal food 6 hours is okay. Now let's go back to our question. Laparoscopic surgery, is considered as high risk aspiration surgery. Otherwise also, why? Because during laparoscopy, increased intra-abdominal pressure will compress stomach, that will lead to distortion of gastroesophageal angle. So LES become incompetent, lower esophageal sphincter become incompetent, increasing the risk of aspiration. So laparoscopic surgery, rather NPO guidelines become very important. So 6 hours may be okay, but in this question there is no choice of 6 hours. So we have to go for 8 hours. Otherwise, in this question, if there would have been choice of 6 hours also, then we would go for 6 hours until unless they have not mentioned that patient has taken non-veg fatty meal. So answer is A. Question number 4. You were somewhere and saw a middle-aged man collapse. You started CPR after checking vitals and soon advanced cardiac life support arrived at scene. What should be the next step of management? Hand over patient to them and leave. Ask them to prepare for defibrillation while you continue CPR. Stop CPR and let them apply the pedals. Continue one round of CPR and then use defibrillator. Again, very important question from CPR is expected, particularly steps in CPR. So what should be the step? Again, this is our screenshot. So if you encounter an unconscious patient, what should be the protocol? Number one, scan for scene safety. Very important to see whether scene is safe or not. It is not that some building is collapsing and you start doing CPR, then somebody will do your CPR. Or if there is accident in the middle of the road, you start doing CPR, then somebody may be doing your CPR on the other side of the road. So scene safety is very important. First thing, scene should be safe, then only act. After scene safety, now next step is assess responsiveness. No, don't straight away jump and start doing CPR. The person may be just sleeping. You know, India, many time people, they in the daytime, full day time, they will just have one or two local desi, and then they will be sleeping even on the roads or footpath. So person may be just sleeping and enjoying his dreams. So don't go and attack. First, you have to assess the responsiveness. I remember a very good incident. We are sitting on a central monitor in ICU, and we had an intern with us. And suddenly we saw that intern rush to a bed and start doing CPR. And patient cried, "Doctor साहब, क्या हो गया? मेरे ऊपर क्यों चढ़ गया क्या आप?" Then we also followed him, and we came to know that we asked why you started CPR. He said on central monitor, straight line was coming. And when we checked, ECG electrodes were detached, so straight line was coming. So assess responsiveness is important. And how you assess responsiveness? By shaking and shouting. Shake and shout. If you feel that patient is non-responsive, then call for emergency medical services by mobile if available, if app is available. In Western countries, app is available. You press the app automatically with the GPRS, they will locate the site and your advanced support medical team will reach. But here we don't have such facility. Here you know that everything app is available, pizza app, burger app, or undergarments app you will see, but nobody is bothered about life app in our country. So hardly, I don't think there is any such app. So that's why. And American Heart Association, they also know that there is not there in majority of the countries. That is why they said if available. So assess responsiveness, and if you have mobile app, then go for. Else, now after assessing responsiveness, assess breathing and pulse simultaneously, and breathing just by scanning. Previously, you know, we used to look, listen and feel. That is not required. Even a layman can tell whether somebody is breathing or not. So just scan the chest movements to see whether patient is breathing or not breathing. Or simultaneously check pulse by putting your hands on carotid. So put your hands on carotid and your eye should be on the chest. So both should be assessed simultaneously, and this should not take more than 10 seconds. If 10 seconds you are not able to assess, please consider it as absent. So if patient is pulseless, breathless, or pulseless, breathless both, Now you have to call for emergency medical services or emergency response team by calling helpline number. Western, you know, it is 911, but India, I don't think since many years, for last I think 7 8 years, we are hearing that government is bringing this emergency response system like Western countries, but still I didn't see any advancement. But for us, so you can call your 101 ambulance services. That's what maximum you can do. That is also often I have seen not working. May I lucky there, or you can again you can call your police, but that again, you know, they are not equipped there. Anyway, fortunately for us, majority of CPR will be in hospital, and hospital you always have chance to activate code blue. So very important, you have assess responsiveness, patient is unconscious, breathless, pulseless or anything. Don't start anything before activating the emergency response team, before activating code blue. Why? For two reasons. One, you are not Rajnikant, so you will need people to do CPR. You need help. One. Second, the cause of cardiac arrest in adult should be considered ventricular fibrillation until proved otherwise. And the management of ventricular fibrillation is defibrillation, which should be done at the earliest. So you have to activate emergency response team so that you can get defibrillate at the earliest. Fine. After activating code blue, now you come to the patient. And there are three situations: breathing and pulse present. So there just breathing and pulse both are present, patient is only unconscious. So here you can just wait and monitor. Then breathing is absent but pulse is present, then you have to give only breath. So if you are in a hospital setup, you can give breath with the bag and mask, but if not in hospital setup, outside, you can give mouth to mouth. However, you are a trained rescuer, so mouth to mouth is only for trained rescuer, not for common man. Fine. But since you are a trained rescuer, so you can go for mouth to mouth. Third situation, which is most often you will find patient to be breathless and pulseless. If that is there, then start CPR. And start CPR starting with the sequence of CAB. C, circulation, A, airway and breathing. And what do you mean by why they change it to CAB? You know, conventional used to be ABC. But in 2010 guidelines, they changed to CAB. And this C means compression of 30 compressions over a period of 18 to 20 seconds. And why they changed it? Because studies have shown that there is enough blood which is in dissolved form in blood. There is enough oxygen in dissolved form in blood. So by giving 30 compressions, you are pushing this dissolved oxygen to brain and heart. So by doing that, after that you go to airway and then go to breathing and continue your CPR till your defibrillator arrives. And as soon as defibrillator arrives, defibrillate as soon as possible, because I told you the cause of cardiac arrest should be considered ventricular fibrillation in adults until proved otherwise, and the management of ventricular fibrillation is defibrillation. So now I think you have understood. Now you have come. Now let's go back to the question and see. You have started CPR, okay, and then team came. Means you are at this stage. You have started CPR. You have reached at this stage, and now the team has come. So team has come means now you have to defibrillate ASPA as soon as possible. So of course, you will ask them to defibrillate. You are a medical personnel, so you can guide, and the team coming will definitely be paramedics. So still, you can guide them. So of course you will not hand over and then just leave. So you will ask them to prepare defibrillation and you continue CPR. CPR should be uninterrupted. Even nowadays, if you are even intubating also, they say you should not stop CPR. And if you need to stop, that should not be more than 10 seconds. So continue CPR is most important thing. So they will prepare defibrillator, and as soon as defibrillator is prepared, you will defibrillate. Fine, now you can understand. You cannot stop CPR. You cannot hand over and run away. And obviously, there is no point of continuing one round of CPR once defibrillator is ready. So continue CPR, and as soon as defibrillator is ready, you just defibrillate. That's what they want to ask. So again, that also I will say is very much expected question. So I could manage to find these questions only. If you have more queries or more questions, you can always post on our your Facebook or to our counselors. Then we'll try to solve as fast as possible. So now I'm going for query session. Whatever query you have, if something not clear, or if somebody among you uh, has another question, or you want to improve some this question with some other choices, you can, because see, this is a memory based question getting from students. So maybe you can expect that question may be little different, or one or other choice may be little different. If you have any of such knowledge, please let me know. I am opening now my YouTube link. Okay. Question getting from students. So maybe you can expect that question may be little different, or one or other choice may be little different. If you have any of such knowledge, please let me know. I am opening now my YouTube link. Okay. Question from students. So maybe you can expect that question may be little different, or one or other choice may be little different. If you have any of such knowledge, please let me know. I am opening now my YouTube link. Okay. Question from students. So maybe you can expect that question may be little different, or one or other choice. If you have any of such knowledge, please let me know. I am now doubts. I'll wait for 1 or 2 minutes, and still, if I didn't get any query or doubt, then I'll close my session. Doubts. I'll wait for 1 or 2 minutes, and any doubt? मोनिका लंगन, क्या एंजाइना का लेक्चर मिल सकता है मोनिका? That I think you need to ask from medicine faculty, or one of our counselor in DBMCI, because angina is not my part. That will be covered in your medicine cardiology. So I'm not finding any queries. What happened? Still, I see there are at least 28 people live I can see, but still no queries. Why? What happened? So should I close the session? Just last 30 seconds I'm waiting, and then I'll close. So you can see that majority of things, majority of the questions are covered from notes, or from our lectures, fortunately. So, okay then, thank you very much, and my best wishes. Still later you have any doubt, as I told you, you are most welcome to post your queries here. Thank you very much for attending, and my best wishes.